Um, so first off, talking about the cardiovascular system, I have to first talk about the circulatory system. The circulatory system is just the system that actually circulates the fluids within our body. So it actually consists of two organ systems. The first one, never mind. So it consists of these parts of it. One is that it contains a pump. Of course, the pump in our cardiovascular system is our heart. Plus, it has a vascular system. So these are just the tubings that transports the fluid from within our body. So when we're talking about the cardiovascular system, this is the blood vessels. Within the lymphatic system, on the other hand, they're called lymphatic vessels. And finally, we have the circulating fluid. So within the cardiovascular system, it's going to be what? Blood, yes. And then for the lymphatic system, it'll just be the lymph. So, like I said earlier, it consists of two organ systems. The first one is the cardiovascular system. And then just breaking down the name cardiovascular, cardio meaning what? Your heart. Yeah, vascular meaning your blood vessels, correct. And so these are what circulates the blood within our body. And within the blood, it contains hormones, gases, nutrients, and waste to be able to circulate around in our body. The lymphatic system is the other organ system in the circulatory system. So this circulates the lymph, like I said earlier. It is part of our immune system, so it does help defend us against infections and diseases. And this is also the organ systems where our fats are absorbed. Remember how when we said that the fats are absorbed where in the digestive system? Or fats are absorbed? Small intestine, very good. And it doesn't go into our blood like all the other nutrients. It actually goes into our lymphatic system first inside these very small lymphatic vessels called lacteals. But you don't have to know that. But I just want you to know that fats are absorbed in the small intestine and it's picked up by the lymphatic system. Okay, we're going to concentrate more about the cardiovascular system than the lymphatic system. So I just wanted to at least give you a heads up what the lymphatic system was about. But the cardiovascular system contains of two circuits. The first circuit is called the pulmonary circuit. And whenever you see the word pulmonary, it always refers to the lungs. So this is the circuit that carries blood from the heart to the lungs and back from the lungs to the heart. As shown over here. So when blood goes into our heart, it's oxygenated. It has poor amounts of oxygen inside of it. I don't like to use the word deoxygenated because when you say deoxygenated, it means that it contains like no oxygen whatsoever. The blood, even though there's lower concentration of oxygen, does have oxygen in it. So that's why when people that's why we do CPR and whatnot, because the oxygen levels within our veins still contains a certain amount of oxygen in it. So we could circulate that blood by pumping the heart manually doing CPR so that the places that needs it most, like the brain and the heart, can still receive some of the oxygen that's getting pumped manually by another person. So it doesn't have that much oxygen at this point, and it contains a lot of carbon dioxide at this point. So this blood inside the heart is being pumped to the lungs so that it could get oxygenated and release the carbon dioxide within that blood out into the atmosphere. Okay, so once we have the blood oxygenated by the lungs, now it goes back to the heart itself. And once it goes back to the heart, so it's oxygenated, and we released a lot of carbon dioxide from the lungs. into the atmosphere, so it doesn't have that much carbon dioxide at this point in time. And so now we go back to the heart itself, as shown over here. So whenever you see this blue, it means that they're oxygen poor blood. So at this point in time, all this blood that's coming from our body goes into our heart. Not that much oxygen, a lot of carbon dioxide. So it's being pumped to the lungs so that the lungs could get oxygen from the air, put it into our blood, and the carbon dioxide that's in our blood released into the air. And that now oxygenated blood returns from the lungs to the heart now. The systemic circuit, systemic meaning the body. Whenever you see systemic, means the entire body. It carries the blood from the heart to the body and from the body back to the heart. So at this point in time, we said that oxygenated blood is inside the heart and then it's being pumped out, as shown over here on the right-hand side. Of course, I gotta get my little cursor out. Like over here. So it goes from the heart, getting pumped out, goes to the rest of our body. And then once it goes to our body, the cells in our body will pick up the oxygen and release carbon dioxide. It also, at the same time, if blood is coming from our gut, it's also getting nutrients from the nutrients that we absorbed in our small intestine. And whatever nutrients and oxygen that it takes in, the cells takes in, they will then release carbon dioxide and waste as well. And that waste will eventually go into like our kidneys to be excreted out. So like I said earlier, cells pick up the oxygen and nutrients from the blood and then empties the waste and carbon dioxide back to the blood. And then now that it's deoxygenated, oxygen poor and carbon dioxide rich blood, it goes back to the heart and this cycle continues. So far so good? Okay, the blood contains, our adult size average person contains about 5 liters of blood. So that's a lot of blood in our body. Since we're talking about blood, we are going to be part of Team Edward today. So, yay. We're part of Team Edward today since we're talking about blood. Anyway, inside blood it contains plasma, and plasma is the fluid portion of blood. And as you can see here, after it gets centrifuged, most of the blood cells are heavier, so it gets towards the bottom, while the lighter plasma, which is just liquid, is this yellowish color here. And this is when it's not centrifuged, so this is freshly taken, so it didn't have time to settle. The blood cells haven't had time to settle yet. And within the plasma, it contains many different things. Hormones, like we said earlier, nutrients, waste, gases, of course, some salts and proteins as well. But yet, once again, it's mostly composed of water. The formed elements are all the cells that we will talk about. First off is the erythrocytes. These are the red blood cells, as you can see over here. These circular disc-shaped cells. The leukocytes are larger cells. Well, some of them are larger, like this, eosinophil. All 3 of these are eosinophils. Here's like a lymphocyte. But these are leukocytes. I want you to know the leukocytes in general, white blood cells. When I was talking about eosinophil and lymphocyte, you don't have to worry about those terms. Platelets are these little itty-bitty little fragments of cells that you see over here. And these help with the clotting process. So erythrocytes are, once again, the red blood cells, and they contain this protein called hemoglobin. Hemoglobin contains iron inside of it, as you can see on this particular diagram. Um, the heme within hemoglobin has this iron atom that binds oxygen to it. So over here, it doesn't have oxygen, and over here, oxygen is bound to that iron within the heme group. And that's how its main purpose, erythrocytes' main purpose, or red blood cells' main purpose, is to carry oxygen for our bodies to receive for our cells. And you'll notice that these cells, they don't have a nucleus, and that's what causes this indentation inside of it. There's this indentation because they don't have a nucleus. They don't also have mitochondria. We'll talk about mitochondria later, but mitochondria is where we produce ATP and utilizes oxygen to make ATP. So it makes sense that if these are oxygen carriers, we don't want these cells to be using up that oxygen before giving it to our cells. So that's why it doesn't have mitochondria. And all this helps increase the amount of hemoglobin that is within the red blood cells itself. So don't think of having only one hemoglobin per red blood cells. There's thousands of hemoglobins within that one red blood cell. So it could carry up to how much oxygen then? Anybody? A lot. Okay, so I don't want you to say it only carries up to 4 oxygen, because once again, it's not just one hemoglobin in a red blood cell. It's many, many, many hemoglobin within the red blood cells. Anemia is a condition when you don't have that much red blood cells or you don't have that much hemoglobin. So this is you basically don't have that much oxygen within your blood. So you tend to feel really tired. People with sickle cell disease, this is when they have this recessive allele. We'll talk about alleles and stuff when we talk about genetics, but someone's genes that has this particular trait tends to cause the hemoglobin to be defective, and so it doesn't have this regular, nice, circular disc shape red blood cell, erythrocyte. Instead, it turns into the sickle shape. This is a sickle here. Sickle shape, due to having lack of oxygen, it causes it to deform in this shape. The problem with this is that it could get caught in blood vessels, so it could cause blockage of blood vessels, and it could potentially cause tears on the within the blood vessels itself. And also the red blood cell itself, when it changes into this shape, it easily damages its own plasma membrane, causing it to lyse. So remember when we were talking about hemolysis, that's when the red blood cells break apart, they burst, yeah. And so this will cause hypoxemia. This is a low concentration of oxygen, and anemia, of course, when we were talking about the low amounts of red blood cells. Say again? It's deadly if you have both traits, alleles for it. Okay, people with heterozygous, meaning that they have a trait of normal red blood cell and another trait for sickle cell disease, then they're able to survive. But of course, like it will be hard for them to do to stay active and things like that, because when they do, their red blood cells will be less oxygenated and causing it to become sickle cell. It could potentially cause blood clots because it being that shape will not fit through like small blood vessels that well, so it will get caught in there and potentially cause blockage of that blood vessel. So it doesn't technically make clots. We'll talk about clots later, but it may block a blood vessel though. So we were talking about just a second ago about people who are heterozygous for this trait. It actually proves to be an advantage for some places that have malaria. Malaria is a parasite that actually feeds on the hemoglobin within red blood cells. So this is transferred using mosquitoes. So mosquitoes carry this particular disease, this particular parasite. And so areas that have a lot of malaria, people with heterozygous of sickle cell disease might have an advantage to that because the parasites cannot attack the sickle cell red blood cells. So they're not affected as well. So locations with a lot of malaria, they either die because of the malaria itself. So people who have normal red blood cells may not survive. However, those that have the sickle cell tend to survive better because they are not as affected by this parasite. And so they pass on their genes to their children and stuff. But like I said earlier, people who have two sickle cell traits for it, or two alleles for it, they die off too. So this DNA is transferred or passed on to generation, and it doesn't die off due to the being advantageous in this particular case, where it protects them from dying from malaria. The other thing about blood is it contains antigens, and antigens are these protein glycoproteins. So it's partially has proteins and partially has sugars on that protein itself. And we talked about self-recognition way back in the day when we were talking about one of the functions of proteins. So it helps us to recognize our own cells so that our immune system doesn't attack our own cells, and helps us recognize what are foreign cells so that our immune system can attack other foreign either bacteria or viruses or whatnot. So this blood cell over here contains this antigen here that's on our plasma membrane so our immune system could recognize itself. So type B, as you can see, has a very similar structure, but you can see how the different monosaccharides here are slightly different from here. Over here it has a one of this amino acid here. Over here it has galactose instead. Bless you. Type AB, as you can see, has both of the same antigens as A and B, while type O has neither of these type of antigens. People with type O will have all types of antibodies for type A and B, but type A will not have antibodies against itself, right? So it won't attack itself. But instead it will have antibodies against type B, and that's why people with donating blood, it would be best if they could donate their own blood type with each other, but since type O doesn't have the antigens on it, it could donate it to other blood types and not be affected as much by the antibodies of other blood types. So these are the four different blood types that we have. I just want you guys to at least know about it. And when I was talking about antibodies kind of attacking the antigens portions of the blood on the red blood cells here. So here is an antibody here within people with blood type B. So if we did mix someone with blood type A with a blood type B person, it will cause this thing called agglutination. It just makes this clumping occurring. The bad thing about this clumping is that it's not going to cause blood flow to smaller blood vessels area, so it's going to cause blockage in those areas, so it could potentially be deadly. Versus if someone with blood type A mixes with their own antibodies of anti-B, it's not going to cause that interaction, so it's going to stay smooth and allow that blood flow to pass through. So on and so forth. So you can notice how for blood type O here, they don't have any antigens with it. So these antibodies, when you put it with the blood type O, there's not going to cause that agglutination to occur. Go ahead, Julie. Oh, that's another antigen on top of that. It's called the Rh antigen. We don't get into it too much in here. When we talk about it in physiology, you'll talk about it some more if you take that class. But yeah, whenever you think of blood type, people say, oh, I'm blood type O negative or something like that. And that's just another type of antigen on the red blood cell itself. And it has its own antibody for it too. So people who are Rh negative, they don't have that antibody yet, but after it being exposed to an Rh positive blood, they will develop that antibody. So that's why women who are pregnant, who are Rh negative themselves, if they're pregnant and have a child that's Rh positive, potentially their antibodies will attack the fetus's blood. So to kind of prevent that from happening, they actually give the mother kind of like it fakes out its own antibodies by letting its antibodies bind to the thing that they inject to the mother to prevent it from attacking the fetus itself. Okay, how do we produce more red blood cells? Red blood cells, yeah, erythrocytes, is through this hormone called erythropoietin. Okay, erythropoietin, or EPO, is produced by the kidneys. So the kidneys are over here. And this causes our bone marrow to increase the production of erythrocytes. So the kidneys produce this whenever we have low amounts of oxygen. So it gets detected and then causes the kidneys and also the liver to secrete this erythropoietin. That's going to once again affect our what? What is it going to affect? It's going to affect what produces red blood cells. The kidneys will produce the hormone that will affect our bones, our bone marrow. Yeah, our bone marrow to produce the red blood cells. So over here, it stimulates the red bone marrow within our bones, and then that's going to cause increase of red blood cells. And if we increase the amount of red blood cells, we're going to increase the amount of what? What gas? Oxygen. Yeah, because there will be more hemoglobin to bind oxygen. Yeah, if we increase the red blood cells, it increases the amount of hemoglobin, which that the body can carry. Yes. So places with high altitude areas, they tend to have high altitude areas has more or less oxygen in that atmosphere. Less, right? So people like us who are near sea level and we go to live in a location or travel to a location at high altitudes, they have less oxygen there. So it's going to cause our breathing rate to increase, right? Because we want to try to increase the amount of oxygen within our own body. Over time, a long time period, it's going to cause our kidneys to produce what hormone again? EPO, yeah, erythropoietin. That's going to cause our bone marrow, right? Red bone marrow to increase in red blood cells, producing red blood cells to increase our oxygen. So people who naturally live in these places will have increased amounts of red blood cells to begin with. That? Oh, no, that's from Uncharted. Yeah, yes. Leukocytes are, once again, what kind of cells again? White blood cells, very good. These help us fight off infections, so this is actually part of our immune system. unlike the red blood cells, they don't have a nucleus, right? They also don't have mitochondria as well. However, they do have a nucleus and also have organelles within them. And you can see on, if I could get my pointer here, this is one of the nucleus of that one white leukocyte over here. Oops. So, not too much to know about this. Just know it's helps us fight infections and allergies and whatnot. And it's different from the red blood cells because it contains a nucleus and its own organelles. However, as you can see, how many of these leukocytes do you see on this one slide over here? 4, right? 1, 2, 3, 4. 1, 2, 3, 4. But how much red blood cells do we see? A lot. So the number-wise, there's not as many white blood cells than red blood cells. What's going to happen to the amount of these white blood cells if we have some kind of bacterial infection? It's going to increase, yes.
So with cancer, they have a lot of red cells?
It depends on what kind of cancers we're talking about. If we're talking about leukemia, yes, we're going to have definitely a lot of white blood cells. Leukemia, leukocytes, right? It's actually a kind of like a tumor that increases the amount of white blood cells that a person has. Not to fight it off, it just like any cancer, it continuously undergoes mitosis to divide that cell. In that particular one, it increases the amount of white blood cells to be increased. It keeps on dividing that type of cell, white blood cells. However, the thing is, it doesn't have a mature leukocyte when they produce that. So although you have an increase of white blood cells, they don't fight off the infections because they're not mature enough to fight it off. So those people are still prone to diseases and whatnot. Finally, we get to platelets. And platelets, once again, are just little itty-bitty little things here. And these are, once again, bits and parts of a larger cell, a megakaryocyte, but don't worry about that. Just know that these are not actual whole cells themselves, but just bits and parts of a larger cell. So when a blood vessel gets damaged somehow, these platelets, they will stick together and try to prevent any more further blood loss. Of course, if you have that massive of damage, even the platelets won't be able to help that person. But so these platelets, they will release these things called clotting factors that will help convert this protein called fibrinogen into the active form called fibrin. And this fibrin is these little stringy things that you see over here. Okay, it's not coming out. These stringy things over here. Okay, I will erase it. But it helps, as you can see, it's like a web. And so it ends up causing this blood clot to occur. It helps bind the red blood cells from being passed through and whatnot. And so it then ends up causing this blood clot to occur. People who are hemophiliac, they have the sex-linked recessive trait that will be deficient for one of the clotting factors. And if they're deficient for the clotting factor, if they do get a cut somewhere, then they're going to end up potentially dying from blood loss, since they're not able to clot themselves.
When you say sex-linked, does that mean gender-based?
Yeah, they're gender-based traits, meaning that only the mother can pass it on to their offspring, type of thing. If the mother, it's a recessive trait, sex-linked trait. So even though she has it, if she's heterozygous, meaning that she still has a dominant trait for it, she wouldn't be as effective. But if her children, like just said, the male had one of those X-linked traits as well, they can pass it on to their children if both of them are recessive, kind of thing. An embolus, on the other hand, is when you have an abnormal amount of clotting occurring. So if that occurs, it might end up causing a blockage of the entire blood vessel, or it could cause an embolus is when actually a part of that clotting breaks off. And if it breaks off, there are locations in our blood vessels that become narrower. And so even though it's broken off, it could clot or cause a blockage of the narrower blood vessels. And that will potentially cause a heart attack if it happens to occur within our coronary arteries. So there's certain drugs like aspirin and heparin. These are called anticoagulant drugs because, like the name implies, it prevents the coagulation of blood, so that it causes it prevents the clotting from occurring, so that we have blood flow a lot smoother through the blood vessels. However, of course, if you're taking these drugs, then you're more prone to bleeding then. And so, like if someone's undergoing surgery, they'd rather not have the person have these drugs in their system. Yeah, these are blood thinners, exactly. So now we're done talking about the blood. Let's switch over to the heart itself. The heart is a muscular organ. It's made up of cardiac muscle. So different from our skeletal muscle, because our skeletal muscle was what we can actually control it. It's voluntary. Our cardiac muscle is involuntary, meaning that it contracts on its own. It has different chambers to it. First one is the right atrium. The right atrium, located over here, receives all the blood from our body. So at this point in time, the blood is not that oxygenated, and it has a lot of carbon dioxide in the body, from the body. The blood then goes from the right atrium to the right ventricle, located over here. In the right ventricle, when it contracts, it will then cause the blood to go up this pulmonary trunk into our lungs. And once it gets to our lungs, that's when it gets oxygenated. And then once it's oxygenated, it comes back from the lungs into the right atrium here. Left atrium. So this is where it receives the newly oxygenized blood and also doesn't have that much carbon dioxide at this point. Blood then travels into the left ventricle here. And as you can see, which side is bigger, looking at the walls of the heart here? The left, right? Does that make sense? Yes or no? Why does it make sense? The left ventricle pumps blood to the body, right? Versus, yeah, go ahead. Not necessarily. I think they stay the same size. Exactly. So think of where it's going to go, right? The right ventricle pumps it to where? To the lungs, right? It doesn't have to travel that far. Versus the left ventricle pumps it to the entire body all the way to your toes. So it has to be a lot thicker, right? To be able to contract strong enough to get all the way to our toes eventually, kind of. Oh, well, it was on whatchamacallit. If you looked at the videos, the YouTube videos, did you watch those? Okay. There was one that was covering that. Yeah.
I think you were trying to trap us up and getting it wrong.
No, I'm not. Really. That was part of your online work, right? To look at those videos and stuff. So. No, I'm not trying to do that. Okay, so we're talking about the different chambers now. Going further about these chambers, in between the chambers, so there's this valves. And the valves prevent backflow from the heart whenever they contract. So first off is the right atrioventricular valve, also known as the tricuspid valve. Tricuspid because it has 3 cusps on its valve. And this is just in between the right atrium and ventricle, hence the name right atrioventricular valve. There's also this valve over here. It's called semilunar valve because of the shape. It's like a crescent moon kind of shape. Once again, it has 3 cusps as well. And it's called the pulmonary semilunar valve because it's going to end up going to our pulmonary tracts, which eventually goes to our lungs. So pulmonary, once again, always think of pulmonary with lungs. So pulmonary semilunar valve. There's the little. And then the left atrioventricular valve is over here. Like the name implies, it divides, it's at the location between the atria and ventricle, and this is where blood passes through from the atrium, left atrium to the left ventricle. It's called a bicuspid valve because there's only 2 cusps in this particular case. And then there's an aortic semilunar valve. You don't really see it that well over here, but you kind of see it. It's just located over here. The aortic semilunar valve is a valve that will go from the left ventricle to the aorta, which is this blood vessel over here. And once again, these valves, its function is to prevent backflow of blood. So it keeps blood going in one direction. So for example, this right atrium goes through the right atrioventricular valve to the right ventricle here. And when the right ventricle pumps, right, it's going to put a lot of pressure. Most of it will go into this location here, going up through the pulmonary semilunar valve into the lungs eventually. But some of the pressure will go towards here. And notice how it's flapped in this particular direction. And if you push force or blood in this direction, it's going to close this flap to prevent it from going back into the right atrium. Does that make sense? Kind of? No. Notice the shape of this. It's kind of curved in like that. So if I end up pumping on this bottom part, pushing force towards this bottom, it's going to cause blood to go in this direction. This direction is okay because, as you can see, this semilunar valve, it allows blood to flow in this direction. It doesn't allow blood to flow back. And if it's talking about this right atrioventricular valve, it's going to close up when we try to push blood against it because it's not in that particular shape. It's kind of angled in this shape here, so when you push blood, it's going to flap and close it shut. Does that make sense? This was just a mnemonic. Not like it really matters for you guys too much, but if you were memorizing it through tricuspid versus bicuspid, an easy way to kind of remember is like you always try on something before you buy something. So tricuspid before bicuspid. So this was tricuspid valve, and this was the bicuspid valve here.
What's the after bicuspid for the left atrium?
Mitral?
Mitral?
That's the type of hat that I think the Pope wears or something like that. It says, mitral. I don't remember the pronunciation for it. Pathway of blood. Okay, so we kind of know a little bit about the pathway of blood. So it's kind of like taking a tour with the magic school bus here. So we shrink down to the size of like a red blood cell per se. So the systemic circuit. What is the systemic circuit once again? It's the circulation of blood through our body all the way back to our heart. Okay, so it starts off with blood entering our heart from our body. So it enters from the superior vena cava, which is over here on the top, this blood vessel on top here. This is the superior vena cava. So blood enters from our head and upper body through here. And through the inferior vena cava. This is blood coming from our lower portion of our body, as well. So it will then go to, what is this chamber again? Your right atrium. So the superior vena cava and inferior vena cava, we have blood entering the right atrium from there. Okay, now that we're in the right atrium, we're going to go through which valve? What is this valve here? The right. It will end up going to the right ventricle, but what is this valve that it has to first go through? Tricuspid, very good. Or right atrioventricular valve, very good. So it goes through the right atrioventricular valve to the right ventricle, like we said. And once we're in the right ventricle, this is the beginning of the pulmonary circuit. What's the pulmonary circuit? Yeah, it's the circulation of blood to the lungs and back to the heart. Okay, so it goes to the right ventricle, and from the right ventricle, it's going to go where? It's going to go through this valve here. What is that valve? No, not quite yet. Bicuspid, we'll get there. But what is this valve here? Pulmonary semilunar valve. Very good. And then it goes to this blood vessel called the pulmonary trunk. The pulmonary trunk will become pulmonary arteries, and then it will eventually become arterioles to capillaries. And once it becomes the capillaries, that's where that gas exchange occurs between the blood and the lungs, so to pick up the oxygen from the lungs and to unload the carbon dioxide to the lungs. Okay, so now we have oxygenated blood that it then carries it towards the heart. So we're going to go through the pulmonary veins now, back to the, what is this chamber? This chamber? Left atrium. Yeah, very good. So it goes to the left atrium here. And from the left atrium, it goes through which valve now, Doug? The bicuspid valve. Very good. Also known as the left atrioventricular valve. Very good. And then it goes into which chamber is this down here? The left ventricle. Very good. So, and once we're at the left ventricle, this is the beginning of our systemic circuit once again. So now that we're here, it's going to go through this valve that you could barely see over here. This is, it's going to be more located over here, but that semilunar valve is the aortic semilunar valve. So it goes through that to the aorta itself, and then to the rest of our body. So once it gets to the rest of our body, the cells of our body will pick up the oxygen from the newly oxygenated blood from the lungs and release carbon dioxide from those cells into the blood itself. At the same time, it's receiving nutrients from the small intestine, from our small intestine, and also releasing waste back into the blood so that it could be later excreted out from the kidneys. Okay, a cardiac cycle is one complete contraction and relaxation phase of the heart. So systole, we talked about this in lab earlier a couple weeks ago. It's just this contraction. Systole itself means the contraction phase of the heart. So this is when we have the highest blood pressure. It makes sense too, right? When the heart contracts, it's going to put a lot of pressure on our blood vessels. This is going to be the highest point of our blood pressure. So this is when blood is pushed from the atria to the ventricles, and also when it's pushed out of the ventricles into the lungs and body. And that's one thing that I wanted to mention, is that although blood travels in that one-way direction that we just went with the magic school bus, blood is continually pumping to our bloods and to our body and lungs at the same time. So it doesn't just pump the right ventricle first and then the left ventricle later. The ventricles right and left pumped at the same time. So blood is going to our lungs and to our body at the same exact time. Okay. Diastole is the relaxation phase of our heart. So this is when our heart is relaxing, and this is going to be our lowest blood pressure. At this point in time, blood is returning to the atria, or returning back to the heart, filling the atria and also filling the ventricle passively, just through gravity and pressure as well. Heart rate. Your heart rate is your beats per minute. That's the units. So rate of our heartbeats. So our normal heart rate, average person, is between 70 to 80 beats per minute. People who are very athletic, what do you think about their heart muscle themselves? Is it going to be stronger or weaker? It's going to be stronger, right? So because of it being so much stronger, they don't have to pump as much, because one pump will be able to provide a lot more volume of blood to the body than our hearts who aren't athletic. So they tend to have a lower heart rate, so 40 to 60 beats per minute. Someone like Lance Armstrong? Thank you. Not Neil Armstrong, but Lance Armstrong tends to have a heart rate of 32 to 34 beats per minute, which is like very, very low. And now there's this new allegation of him taking doping and stuff. And one of those doping substances was EPO. Well, what's EPO again? The erythropoietin. What does that do? It causes your red bone marrow to produce red blood cells. Yeah, if you produce red blood cells, you're going to increase the amount of oxygen in your blood. So here, did he really? Interesting.
He probably doesn't get that drunk after like 6 beers, huh?
I don't know about that, because I don't know how it affects his the alcohol levels, how it will affect his brain. That's a little different, but I don't know. Maybe not. I'm not sure. Heart sounds. Okay, whenever we talk about the heart sounds, when we actually listen to someone's heart, you're actually listening to the valves closing. So the first heart sound, the lub, whenever people talk about the heart sounds, they call it lub dub. I don't know why, but so be it. I guess it kind of sounds that way. So this is when there's this turbulent blood flow that hits the valves, causing it to shut. So this is that first sound. The second heart sound, called the dup, is when it hits the semilunar valves, ends up closing. So that's the second heart sound. There is something called a heart murmur. This is an abnormal heart sound when there's not a normal flow of blood inside the heart. So here are some examples of it. Let me see if I can. Heart murmurs, if they don't end up having completely closed or normal forming valves. Thank you. It makes sense too, because they're still developing, so they might not form it completely yet.
Yeah, that's something, because my daughter had that.
Mm-hmm.
I told her that, or I went to see a cardio doctor.
Cardiologist.
Yeah, there we go. And he told her that, or he told us that when the older she gets, the less she'll be able to hear it.
Yeah. Yeah. So, I mean, but in some people, it is something to be concerned of as well. So let's see if I could get this. I don't know. Okay, we can't hear it. I'll try to get it to work later or something. I'm not. So the heart also has an electrical conduction. We talked about electrical conduction within the neurons, right? But within the heart, they also have electrical conduction as well. It starts off with a pacemaker called the SA node, sinoatrial node. It starts here near the right atrium here. And these are specialized cardiac cells that spontaneously depolarizes or spontaneously activates because it's just these are specialized cells. They have leakage channels. Don't worry about it. But anyways, they spontaneously cause this hearts to be started, to cause it to beat. So it spreads from the SA node across the atria, both the right and left atria, and then converges down to the atrioventricular node here, or AV node. When it contracts, when it causes that electrical signaling, it's going to first cause the atria to contract, both of them, and then it converges at the atrioventricular node here. And at the AV node, it's then this electrical signal will actually go down this wall here through a series of conduction systems. It goes down, the bundle of His, but before I go into that, the AV node actually delays it for a second. The reason why it delays it there is for the atria to finish contracting and filling up the ventricles before the ventricles contract. We want that delayed so that it has proper filling, to have the maximum amount of filling of blood into the ventricles before it contracts. If it doesn't have that proper filling, then we're not going to be contracting optimally all the blood that's within our body. So there might be not enough blood to certain locations on our body. Okay, the atrioventricular bundle of His is located over here. Just know that these are located within the walls here. So at this point, there's no electrical conduction outside of the wall, so we don't have contraction of the heart muscle yet. It just conducts the electrical signaling down this bundle of His to the right and left bundles here. And then you'll notice how it goes to the Purkinje fibers here. So these are Purkinje fibers, so the message from the AV node down to the bundle of His to the right and left bundle branches, and then the Purkinje fibers. So this message goes downwards and then back upwards, so that at this location here where it gets to the Purkinje fibers, that's when it actually causes the ventricles to contract. So the ventricles contract from bottom upwards, and that kind of makes sense too, because most of the blood is located here, right? If it contracts from up down, then it's going to cause the blood to try to go down here, but there's no opening on the bottom of the heart. So if it causes the contraction starting from the bottom portion towards the up, it's going to push the blood in this direction, right? From bottom up. So that's where we want blood to go, through the pulmonary trunk and through the aorta. Does that make sense? If you're pushing it from the bottom, if you're squeezing it from the bottom over here upwards, it's going to push the blood up, right? Versus if you push it from the top portion, the blood is not going to go through those blood vessels on top.
So that's why when you already did the bottom.
Not necessarily. The thing about the heart, it's just structured that way. So if you push pressure on it, it's going to cause pressure to squeeze out the blood from the heart. The valves, once again, will shut to prevent backflow of blood, so you don't have to worry about that. As long as you're putting enough pressure on the person's heart, you're going to pump the blood out of the heart. Yeah. Artificial pacemakers. These are pacemakers are these electronic devices that help initiate the SA node to start. This is when they don't have a normal, aren't able to produce their own pacemaker heartbeat. The SA node is not functioning correctly, and so this artificial pacemaker starts it off so that they have a normal heartbeat and heart rate. I think that's a good question. I don't know what causes them to have so something like a heart attack or something that causes those heart cells, those specialized heart cells, to not function anymore because they died off or something like that. Then they might need a pacemaker to cause that beating to begin again. There are chemicals that affect the heart. We already know about the sympathetic nervous system, right? What kind of things does the sympathetic nervous system release? Epinephrine and norepinephrine, yeah, which is adrenaline, right? So that increases the heart rate. We know that already. Caffeine, we also know, also increases the heart rate as well. So both of these chemicals increase heart rate. There are chemicals that also decrease heart rate as well, but we're not going to go into that. Electrocardiogram is an ECG or EKG. This is a graph that you could see the electrical conduction of the heart, and it helps us to diagnose any kind of abnormalities that are talking about the conduction of the heart itself. And you can also potentially see a heart attack as well. So it starts off with the P wave, located over here. So the P wave actually shows the electrical conduction of the SA node and also the depolarization or the contraction of the atria as well. So here is just the electrical conduction from the SA node, basically all the way to pretty much the AV node. Soon afterwards, you're going to actually have the atria to contract at that period of time. The QRS complex is the wavy line that goes up and down. This is the ventricular depolarization. This is when you see all that signaling from the AV node to the bundle of His, to the bundle branches, to the Purkinje fibers. All that electrical conduction from the middle portion of the heart that we saw earlier here. This is what causes the QRS complex, this conduction that occurs there. And because it's a lot larger, the muscles there are a lot larger, and the conduction there is going to cause a lot larger deflections of this graph. So this is the depolarization, the ventricular depolarization. Finally, we get the T wave over here. This is the repolarization of the ventricles. So it causes, soon after this, it causes the ventricles to relax. So the P wave, once again, is the electrical conduction for the atria. Soon after that, you cause the atria to contract. QRS complex, it's the electrical signaling could cause the ventricles to contract. And then soon after that period of time, you'll have the ventricles actually contracting. And then the T wave, once again, is where the ventricles repolarize so that over here the ventricles relax. You might wonder where the atria is relaxing at. This is getting covered by the QRS complex here. The QRS complex is so big that you don't see the repolarization of the atria. Yeah, this is a normal EKG. We don't have, I do have pictures of it. I don't have one in this particular slide. But sometimes you don't see any P wave or something like that. Things like that do occur. Or sometimes you skip a beat. Normally there's, once again, how many beats per minute? 70 to 80 beats per minute normally. So if I said that so over here you see that there's this interval here, right? There's a heartbeat here and another heartbeat eventually there too, right? But if I said that the previous one behind this was like this over here, well, that was ugly, but it means that their heart rate is a lot slower in this particular time interval versus this time interval here, right? So you can see all these different things. But once again, this is just the electrical conduction within the heart itself. We're just seeing whether or not the heart is functioning properly or not. So when we actually cause defibrillation to occur, when someone's going under cardiac arrest, or if their conduction of their heart is abnormal, they purposely defibrillate. This is just causing an electrical shock. The electrical shock actually causes this electrical conduction to stop completely, purposely so that the SA node can pick it up again and start this normal ECG to occur again. Does that make sense? Yeah, so we end up shocking the person, causing them to flatline for just a second so that the SA node could start this rhythm again so that it's back to normal. Okay, blood vessels. Blood vessels, once again, are these passageways where blood travels. Arteries. Very important. Arteries are not always oxygenated, okay? They're usually colored in red because they have oxygen, and for most purposes, most of the arteries are oxygenated. However, not all of them are. Case in point, when we're talking about the heart here. When we're talking about the heart here, so as blood travels from the right atrium to the right ventricle, it goes through what valve here? No, not tricuspid. It goes through the tricuspid valve over here from the atria to the ventricle. But what valve is over here? Yeah, it's a semilunar valve. Which semilunar valve? The... Where is it going to? No. The lungs. It's going to the lungs. So it's going to be called starts with a P, pulmonary semilunar valve. Okay, and this is a pulmonary trunk. And what is this then? Going to the pulmonary arteries or veins? Arteries, because it's having blood going away from the heart. Notice how it's blue here, right? So not always all arteries are red, okay? So don't think of arteries always carrying oxygen. That's not true. So arteries carry blood away from the heart. So how I memorize it is the A going away for arteries, right? They tend to have this elastic outer layer, and it's helpful because it helps stretches the blood vessel itself. And it makes sense too because when the heart pumps, it's going to put a lot of pressure on the blood vessel itself. So when you have a lot of pressure, it allows it to expand a little bit. And during diastole, when the heart is relaxing, that expansion will cause the blood pressure to remain the same because it recoils back to its normal shape. Once it recoils back to its normal shape, it's going to push that blood even further. So our blood pressure will kind of remain the same. The first blood pressure pump is by our heart. The second, maintaining of the blood pressure, is the elastic recoil from the blood vessel, the arteries. I don't think it's a vacuum. It's just if you just think of any kind of elastic, just say a rubber band. If you push pressure on it, it's going to recoil back to its normal shape. Yes, it's stretching because of the blood being pushed against it. Not only that, it has a thicker smooth muscle layer. Notice how this smooth muscle layer is a lot thicker than the veins here. The smooth muscles will allow vasoconstriction and vasodilation to occur. Arterioles are these smaller arteries. And then eventually the arteries will become capillaries here. And capillaries is where this gas, nutrients, and waste exchange occurs. So when we're talking about the capillaries in the lungs, we're exchanging what? Oxygen, right? From our lungs to our capillaries, pulmonary capillaries. And we're talking about carbon dioxide is be from our pulmonary capillaries to our lungs itself. When we're talking about going to the capillaries in our bodies, then our capillaries will be delivering what? It'll be delivering actually oxygen to our body cells, right? We're delivering oxygen to our body cells, and then the body cells will release carbon dioxide into our blood, so it goes back to our lungs eventually. Okay, of course, nutrients is once again to our cells and waste from our cells into the blood. And once we come from the capillaries, it becomes venules, which are just very small veins, and then it forms this vein itself. The vein, there's different properties to it. The outer layer doesn't have that elastic property. It doesn't need it because there's very low blood pressure at this point in time. There's a lot more veins than arteries, partially due to it helps decrease the blood pressure even more so, and it also serves as a reservoir for our blood as well. And then there is a thinner, smoother muscle layer due to it doesn't need to vasoconstrict or dilate as much. Finally, they have these valves here, and like all the valves that we were talking about, what's its function then? Yeah, prevent backflow, right? If blood is going in this direction and there's so much low blood pressure, it's going to have to go against gravity, right? And so if it's against gravity, blood is going to naturally tend to go downwards. And if it goes downwards, we don't want blood to we want blood to go to the heart eventually, right? And so we don't want it to go in the opposite direction. So the valves prevent the backflow of blood. Within our capillaries, we have very leaky walls. And it's leaky so that we could have that exchange to occur. We could have gas exchange, nutrients exchange, waste exchange, hormones to pass through them. So all these molecules will be able to diffuse out of the capillaries into the interstitial fluid, which is our tissue fluid, which will eventually reach to our cells. So it's just all through diffusion. And waste and carbon dioxide diffuses from our cells through this interstitial fluid to our blood and releases it into our blood capillaries. Okay, blood flow through our veins. So at this point in time, we said that blood pressure is very low. So partially, the venous valves that we were talking about earlier prevents backflow, right? The skeletal muscle pump is when our skeletal muscles contract. Whenever we're contracting, we're going to be pushing against the veins itself. And when we push against it, it's going to cause blood to flow back towards our heart. So as the skeletal muscle shows here, once it contracts, it's going to push pressure against the blood vessel, pushing blood in this direction. Of course, it could potentially push blood in that direction as well, but due to the venous valves, it's going to prevent it from going any further. And to demonstrate your venous valve, you can actually see your venous valves in effect. If you look at your hand, you'll notice your veins here. If you were to push against the vein in one direction, you'll notice that it collapses. So if you're putting your finger on one of your veins and then go towards your finger, you'll notice at locations that will totally disappear. If you go in the other opposite direction, you'll notice that it's continuous. So you'll notice that there's like a venous valve at certain locations versus others. You guys see that? No? If you go towards your fingers, if you use your finger and then push against one of your veins that you see and go away, and you'll notice that your veins will collapse in one location versus when it's getting closer to you, it doesn't work. You don't have venous valves on your veins. Varicose veins, yes, they don't look that pleasing. Are these veins usually within the leg that tend to stretch and enlarge to the point that the venous valves are not functioning anymore. So the veins actually continue to grow larger and larger The problem with this, it could cause cramping, first of all, but another, besides it looking not so pleasing, it could potentially cause blood clots as well to occur.
What is that? They're painful?
They could be painful, yeah, I'm sure.
It just does it happen?
It happens due to the venous valves. Like if you're like age will cause the venous valves not to function as well as before, and then when you don't have that venous valve, then what's going to happen to the blood? It's going to like build up, right? It's not going to go in one direction anymore, so it's going to accumulate and then put a lot of pressure on the blood vessels itself, causing it to elongate and expand. Yeah.
So wouldn't they give them like blood thinner pills?
They might end up. I know definitely you could surgically remove it, but even blood thinners, it doesn't really matter too much because the blood still accumulates in that vein. Does that make sense? Because there's gravity is going against the blood, right? So it doesn't go back to the heart anymore. So it's going to accumulate in that area. So even if you have blood thinners, it's not going to help it much. You're saying for the blood clotting portions of it, right? Yes, that will help it for the blood clotting portions.
Does that have to do with legs?
Yes. If you have if you have an increased weight, that means you're going to end up increasing the amount of pressure on those areas, which can potentially cause varicose veins too. Okay, blood pressure. This is the force that, once again, is exerted on the blood vessels. Once again, the unit is millimeters of mercury. Really important to know. It's a measurement of pressure.
BP is in British Petroleum.
No, not British Petroleum. Okay, you use a device called sphygmomanometer, which is that blood pressure cuff that easier to say, but that's its technical name. So you usually measure your brachial artery, which is located on your arm. Your systolic pressure, once again, systole means the contraction of the heart. So it's going to be the most amount of pressure at this point. So it's the peak arterial blood pressure.
Who made up these words?
Systolic versus diastolic.
No. Measured by a...
Sphygmomanometer.
Sounds like a tongue twister. Why is it so long?
Diastolic pressure is the minimum amount of pressure, arterial blood pressure. And during ventricular diastole, once again, is the relaxation of the ventricles. So your blood pressure will be the least amount at that point in time. So normally, on average, the normal person, 120/80. So what is 120 then? The systolic pressure. The 80 is diastolic. What's the measurement or units? 120. Yeah, you'll say 120/80, correct. But if you're just saying what's the systolic pressure, it's 120. What's the units again? Millimeters of mercury. Yeah, mercury is Hg.
Just said that, sorry.
No, it's all good. But yeah, when you read that, it's 120/80. That's how you would say it. People with hypertension, this is when they have chronic amount of increased blood pressure. They tend to have a resting blood pressure of over 140, 140/90. The thing about hypertension is that it could cause weakening of the smaller arteries because there's constant pressure against it. So it also may cause aneurysms. And an aneurysm is this ballooning of the arteries themselves, and potentially can rupture, like this over here. And it also can cause atherosclerosis, which we'll talk about in the next slide. But diet and exercise can help prevent or control hypertension. of course, blood thinners as well and whatnot.
That's what I think.
Yeah. Cardiovascular disease, disease of the cardiovascular system, so the heart and blood vessels, causes 40% of all deaths in the U.S., so very prevalent. Myocardial infarction, this is a fancy word for a heart attack. So whenever the coronary artery supply blood to the heart itself. So when a coronary artery gets blocked, it's not supplying enough oxygenated or nutrients to the heart, causing those heart muscles to die, cardiac muscles to die. Atherosclerosis, this is a chronic cardiovascular disease, and this is when plaque, this fat deposit, ends up building up within the blood vessels of the arteries. As you can see, it could potentially block it completely, but more importantly, we talked about it earlier, like about embolism and stuff like that can occur due to that atherosclerosis. So diet and exercise can reduce the risk of cardiovascular diseases. Angioplasty, this is when you put a catheter, this little balloon, to go to areas with plaque, and then you inflate that balloon, causing the plaque to kind of be pushed against the blood vessel wall to, once again, enlarge that passageway for blood to go through. Stents are these wire mesh that goes through the blood vessel itself, and when you inflate a balloon inside the stent will remain in that shape, and causing an opening of that blood vessel. A bypass surgery is when you end up putting a blood vessel from another location of your body, usually from the leg, and then you put it towards your heart, and you basically bypass the location with the blocked artery, the artery that doesn't have that clear passageway. Yeah. Mm-hmm.
That blocked parts, can they like cut that out and stitch the other part of the veins together?
It won't be able to stretch far enough. That's why.
Have they created a little piece to be able to stick together?
And so instead of doing that, they end up getting another blood vessel from another part of your body and just directly, they end up stitching it so that it goes past that blocked artery area. I don't know how they do it, to be exact, whether they sew it together. I don't know how they do it. Yeah. Uh-huh. Yeah, they I think they could leave it in permanently. That's fine. Yeah, thanks. The wires themselves,
There
though,
are stents that are,
stitches.
no, they anesthetic. They provide some sort of anesthetic and they dissolve after they're done.
That's pretty cool.
Yeah, that's kind of a new thing like in the past couple of years.
That's pretty cool. Finally, there's such things called heart transplant. But heart transplant, you could either replace it with another heart or an artificial heart. The thing about all these, well, at least these latter ones, even though we do all these different things, yes, it's the easy way to do it and things like that. However, if the person who are undergoing all these different treatments still lives their lifestyle the same way that they live, it's going to all happen again. So once again, diet and exercise is the most important to help prevent cardiovascular disease. So even if you have an angioplasty or a stent or whatnot, you're going to end up having atherosclerosis again if you don't end up changing your lifestyle. Acknowledgements, pictures, and more pictures. So pause it here.